Okay. Okay, you see me again. You guys see me all day long in the room. Start from the first session. Now I'm going to moderate the second sessions on portal hypertension. We have three distinguished speakers to deliver the lecture. I will start the first one. Professor Xianglong from China. He's going to give a talk on emerging non-invasive method for evaluation of cirrhotic portal hypertension. Professor, please.
Okay, good morning, everyone. I'm very happy to share this the lecture, and also our group was really dedicated to this area over the past 15 years. So today my topic is emerging non-invasive methods for portal hypertension in patients with cirrhosis. Most of the data was from our trials. And I'm Xiaolong Qi, the founder and chair of CHESS. The full name is Liver Health Consortium in China. And also, we have our official journal called Portal Hypertension and Cirrhosis. I have nothing to disclose. So why we should talk about this topic? What the meaning of a non-invasive method? I think I can use these slides to give you an idea. Editorial comments in the Lancet in 2019 that prevention of decompensation in cirrhosis is a new use of beta blockers. But how to help us to guide the beta blockers? We should have a non-invasive. So in this study, Lancet paper by the Valena, they use it's a RCT trials. The beta blockers show the promising results to improve the survival of the patient with compensated cirrhosis. And also the Baveno 7 recommended these recommendations. This is a predicted trial. So let's look at the details of about the patients in this paper. This is a patient's compensated cirrhosis without any decompensation, without high-risk cirrhosis, but with the HVPG invasive measurement more than 10. Even though we have the positive results to show the improved outcome, but the problem is this paper already published 5 years ago. But I do believe in most of the centers, including China, we never use this criteria to select patient for beta blocker. Why? Because the criteria is invasive. So we really need a non-invasive to guide the beta blockers. So this is another ongoing trials by our group. This is randomized double-blinded placebo-controlled trial. We use a carvedilol to prevent decompensation in patients with clinical significant portal hypertension, but stratified by liver stiffness more than 25. So the only difference between this ongoing trial and the predict trial is we use a non-invasive as a selection criteria. So the patient with liver stiffness more than 25 without high-risk cirrhosis was enrolled. Then we do the central randomization. And in the control group, patient receives a placebo, and the experiment group receives a placebo. This is double-blinded multi-center follow-up at an interval of 6 months. And we also measure spleen stiffness, the baseline and the first follow-up. The primary outcome is first decompensation, and it's all liver-related outcomes. So we will treat until the first primary outcome or the complication of a 3 years follow-up. This is ongoing trials in China. And currently, update until yesterday, I updated the results here. We already recruit the 19 cases from 8 university centers in China. I think maybe I will show the preliminary results in APASL 2025 in Beijing about the preliminary results here. So just to give you an idea about why we need a non-invasive, because we really need a non-invasive criteria to select patient for the beta blockers in the very earlier stage. So this is a really focus of CHESS I call Liver Health Consortium. The last December, the Science journal used one whole page to report our group. If you're interested, maybe we're very happy to collaborate with you. And until now, we have leaded the 39 the multi-center trials, including 8 international trials on this topic, and we have a couple of publication in this area. I just selected the couple of trials to share with you. Because in China and most Asian Pacific countries, for all the cirrhotic patients, we will do the CT scan angiography for these patients. So in the very early stage, we use a CT to do the 3D construction and connection with biomedical engineering to do the computational fluid dynamics. This is a non-invasive to mimic the port pressure gradient. The first trial of the chest in 2016, because our group was founded in 2016. This trial, we do the similar thing, non-invasive simulation, and with all patients, 102 patients with invasive HVPG as the reference standard. It shows the satisfied performance with the AUC more than 0.85. And we already have some patents from China and from the United States. And this is comments from NIH radiologist ready for prime time. I also want to highlight this study we just published last year in radiology, because in practice, you know, the radiologists help us a lot, but they can only give us like a port wing diameter or port wing velocity. This is the only parameters we can get from the radiologist or the ultrasound medicine. Actually, we can have a bunch of quantitative parameters. For example, the whole vessel volume, the average vessel curvature, or the number of punches, or the density of the vascular. Actually, a bunch of quantitative parameters we can get from the CT image, but in clinical routine practice, we cannot get them. So in this study, we have around like 200 parameters from imaging only, and we construct a model for the clinical significant portal hypertension based on the CT or MRI. And also the Dr. Scott Reeder, who is the chair of the International Society of MRI, write a comment on our study. So based on our preliminary results, I would like to share our concept, which was not published yet, but we are almost finished this review. We call the vast omics of the liver. So this is 2 words. The first is vascular. The original words of a vascular is a vas, V-A-S, and omics, you know, the genomics, proteomics, or a bunch of omics data already. So the vast omics is a novel concept, which have 5 category parameters, including anatomic, morphology, or topology. The second category is biochemical, like the hemodynamics or the mechanics. The third category is biochemical, some serum biomarkers in this category. And the fourth is the pathophysiology, because CT, MRI, and ultrasound can only see the macrovascular. If we want to see the macrovascular, we have to use pathology images to help us to get this data. And the last category is the experience or the compensant data. So we have this new idea about to give you figure out the whole picture about the vascular of the liver. We will publish this review soon. So we hope to in different countries can test this now omics still available in your disease. Although the concept is new, but actually the quantitative vascular parameters is not new. If you just search in a PubMed or Web of Science, you can see a bunch of literature in this field already published in the past decades, and it's increasing. Almost every year, there are more than 2,000 publications in this field. And definitely, we have several the issues need to dissolve in the future. So this is a brand new idea. So I would like to share with you now. And some other AI or the machine learning based method although we have several publications in clinical gastrohepatology and use radiomics in eBiomedicine, one of the Lancet series journal, and also use AI for the HVPG in cell report medicine. But to be honest, I don't really believe this method can really help us for the routine clinical practice because the quantitative parameters here is very, very difficult for our physicians to understand. So the parameters in the vasomics, like this, the parameters of the vascular, we can really understand, we can easy to integrate our routine practice. So in the next 3 to 5 years, our group really put a lot of time about the vasomics and translate to a product like a post-processing workstation. This is our patent, and we try to collaborate with the industry in this area to translate to a product like the HVPG non-invasive workstation, which we can easily input the DICOM image from CT or MRI, and we can give the results to the physicians, hepatologists, or the gastroenterologists to help us to identify the high-risk patient with CSPH and then get it the beta blockers therapies. And we summarize our our work and also the challenges in this field in the Lancet Gastrohepatology a couple of years ago with Dr. Sorin, Dr. Annalisa Bzagni, and from Switzerland, and Andres Kanners from Barcelona group. And in the recent ESO guidelines and the Lancet Commission paper also highlights a couple of our studies in this field. And also this year, only 2 months ago, we have new cell markers called Golgi protein 33, GP73. Preliminary data showed that this GP73 is useful for the HCC prediction and fibrosis, but we also demonstrated it can also use for the clinical significant portal hypertension, which just published in GMV. And we non-invasive the test are not only useful for the patient with cirrhosis. We still have another trial with the impact of clinical significant portal hypertension on HCC, hepatocellular carcinoma, with the TACE. We show if the patient with CEPH or without CEPH, even we have the similar treatment with the TACE and immunotherapy, but the survival is quite different. So non-invasive test is still useful in patients with the HCC. In China, we have just a registered international society we call the ISMIL, International Society of Multidisciplinary Intervention Oncology. We will have an annual meeting every year, and this year in the June 6 to 8 in the Suzhou, and welcome you to join this topic if you are interested with the cellular carcinoma. So we know the etiology in the most of the Asian Pacific countries is different from Western countries. So we want to validate a model which can be useful to predict not only the clinical significant portal hypertension, but also the decompensation of the patient. So this is the second trial in the 2021. We collaborate with a couple of countries in Asia Pacific, including South Korea, Japan, India, Turkey, and in India. So we combine the couple of non-invasive parameters, including the TE by the FibroScan and some several biomarkers, probably albumin, to construct a novel model we call CHAS-CIF score to stratify the risk of not only CSPH, but also the decompensation. This is work published in American Journal of Gastroenterology, and around 12% patient in the high risk will have a very high risk of decompensation in the next 3 years. The easiest non-invasive way in clinical practice definitely is liver stiffness measured by the FibroScan. Our previous work also collaborate with our Japanese colleagues, Hiroko Emoto from Hanbin College University, and also the Tianyong Kim from South Korea, Anshin University. We have 3 country the cohorts with the follow-up more than 10 years to show if the patient with liver stiffness more than 25 have a very poor outcome compared with the other group. So we have the algorithm with the liver stiffness more than 25 as a high-risk patients. This is also the reason we kick off the RCT trials. As I mentioned before, we use the liver stiffness more than 25. But as I mentioned, this is the easiest non-invasive ways in routine practice, but it's not the best. So we start from using liver stiffness to guide beta blocker therapy. But I do believe in the future, we have a better non-invasive method to help us to guide the beta blocker therapy in the near future. And I would like to also show one of our original study, which was just published the 1 month ago. In China, we have a novel technology called a magnetically controlled capsule endoscopy, which means the patient swallow a capsule and then it has a camera inside. It can help us to screen your varices. But the problem is when the patient swallow the capsule, it will go directly or very quickly to the stomach. It will always miss the esophagus in your the varices in your esophagus. So we develop a string, detachable string, can help us to stable, make the capsule stable in the esophagus, and then it can detachable. The first trial in 2018, led by the Charles, we demonstrate the useful for this novel technique and published in Lancet Regional Health. And 1 month ago, we further demonstrate this technology with 624 patients, decompensating cirrhosis, use this novel technique, magnetic control capsule endoscopy, with all the electronic endoscopy as a reference standard. This work just published in the British Medical Journal in 2025. The limitation is a little bit expensive of this capsule. And do believe in most of the countries in Asia Pacific, maybe you don't have this the machines, but even in China, we have the machines, but the capsule is very expensive. So it can only use for selective patients. And as I mentioned before, the CHESS is already a couple of years in this field. And years ago, we try to have our official journal, which is very dedicated to the portal hypertension and cirrhosis. So the name of the journal is the portal hypertension cirrhosis. Definitely, we have a bunch of very good and well-known journals, including Hepatology International, Journal Hepatology, but this is unique, and this is the only journal focused on the portal hypertension and cirrhosis. And we already indexed in Scopus and will be indexed in the ESCI next year. And if you are really dedicated to this area, we welcome your submissions. And maybe you have seen some of pictures or the cartoons from our group is looks good because we have special specialist in our group. We call the liver art. There is one of the artists in our group to help us for all the different cartoons. This is very important for our submissions, especially in the high level standard. Eye catching the cover or the graphic abstract is really important for us. And the annual meeting of the CHESS will be in the December 6 to 8. It's fixed every year. Every year, December 6 will be the CHESS meetings. This year will be Shenyang, and really hope you're coming, not only for communication, but for more collaborations focused on the cirrhotic patients in the Asian Pacific countries. Thank you very much for your attending.
Thank you, Professor Keith, for that very extensive your study and partly on the non-invasive technique to measure the portal hypertension. We'll keep discussion at the end after 3 presentations, so we'll come back to you later. Thank you. So now we move to the second presentation, that by Professor Hideki Kobara. He will be sent on the current endoscopic gastrointestinal intervention and management. Professor Kobara, please.
Show slide. Thank you. Thank you, Chairman. My pleasure to have this opportunity. I appreciate for President Professor Shina and Honorable Professor Omata. Today, I want to focus on current endoscopic interventions and management. I'm from Kagawa, located in the west of Japan. In Kagawa, Sanuki noodle is delicious. There are many beautiful sightseeing spots. Please come here. Today's agenda as follows. First, ESD to EFTR technique. Let me mention the trend of endoscopic treatment. 80s, EMR began. 2000, endoscopic submucosal dissection, ESD, is now standardized. 2020s, full thickness resection, EFTR, is under investigation. In the future, robotic surgery would be developed. This paradigm shift is 20 years cycle. Important elements of ESD include knife traction strategy. A cutting knife is categorized into pulling type and pushing needle type. My best favorite knife is Ori's Pro knife from Boston Scientific. This has one significant advantage of sufficient submucosal lifting by a chip needle. Show video. This knife has high injection ability. We need no exchange of injection needle, cutting, injection, sufficient lifting. During cutting, so sufficient lifting can avoid incidental perforation. Traction. Clip with line is popular, like surgical left hand. Handmade ring thread is also more effective and cost-effective. A multi-loop traction device is now commercialized. We can obtain sufficient operation field. Training can dissect submucosal layer safely and effectively. Our recommendation of ESD strategy, colorectal ESD, we introduce pocket and ring method called PRM, 10 millimeter submucosal pocket creation. Next, for circumferential cutting. Next, ring traction. Finally, complete submucosal resection. Show video. This region is located in the cecum. First injection, 10 millimeter submucosal pocket creation. Next, for circumferential cutting. Ring traction tool is anchored into the pocket. The ring is anchored on the opposite side. We can create operation field. So training also dissect submucosal layer effectively and safely. complete resection. According to our study for training, the procedure time was shorter in PRM group than conventional group. Moreover, additional device usage was fewer in PRM group, leading to the cost efficacy of PRM group. Some causal toward some causal layer from some causal layer toward deeper muscle layer, endoscopic surgery is advanced. Let me mention human pure EFTR history. First report from China, Professor Pinhong Zhou. Most studies from China. Currently, EFTR is a hot topic in Japan also. Our review summarized that complete resection rate was 99%. Major adverse events was low with 1.1%. Surgical rescue rate was 0.5%. It's acceptable procedure. Post-EFTR defect closure means include pastoring suture using end loops, PSS, and over-the-scope clip, OTSC. PSS is more cost-effective, meanwhile, OTSC is more robust. Let me introduce simple OTSC closure using dual grasping forceps. This procedure enables to grasp serosa muscle layer easily. Inverted full thickness closure can be achieved. Show video. Just located in the upper stomach. After resection, OTC is applied. Grasping forceps grasp the full thickness layer. Additional grasping forceps perform same manner. Suction into the cap. OTC fire. Full thickness closure can be completed. Exposed mucosal layer was closed using end clips. Laparoscopic view reveals this is camera. Reveals inverted closure and no air leakage. Next, endoscopic defect closure. Iatrogenic perforation and delayed adverse events sometimes occur. The management of complication is crucial. Our group had focused on endoscopic closure. From 2013, we introduced first clinical application of OTC in Japan. And then innovative techniques are developed. Last year, we launched Japan's first endoscopic suturing device. This is ESD-associated adverse events incident rate. Delayed bleeding was higher in high-risk group with antithrombotic drugs in overall organs. And delayed perforation was highest in the duodenum. Clinical question CQ1, need for prophylactic defect closure. Our current review summarized that closure provided positive reduction effect for delayed bleeding in overall and delayed perforation in the duodenum. CQ2, technique suitable for prophylactic closure. The ability acceptable for closure techniques need large defect closure more than 3 centimeter, procedure time less than 20 minutes, and complete closure rate over 90%. Closure techniques are categorized clip-based techniques, mechanical clipping like OTC, and surgical stitch-based techniques. Let me mention recent clip-based techniques of hold and drag, detachable end loop, line closure, mucosa submucosa, and water, EVL band ligation method. Unique technique. My colleague, Dr. Nishiyama, has developed endoscopic ligation with O-ring closure, E-lock. First, clip anchoring of nylon loop on the both edge. Second, pulling nylon loop. Third, capture of deployed clips into the cap. Fourth, EVL O-ring band ligation of clips. In the center of the effect, additional clips is anchored on the muscle layer to prevent submucosal dead space after closure. Show video. Clip anchoring of the nylon loop on the both edge. EVL device is applied. Grasping nylon loop, pulling the nylon loop, capture clips into cap, O-ring band ligation. In the center, muscle layer anchoring, 3-point anchoring, grasp the nylon loop, pulling the nylon loop into the cap, and hemoclips, band ligation. The defect was completely closed. New device technique, twin end clip from China, one side clips, opposite side clipping. The defect is approximated. It's a simple manner. Helix stack from USA, one side anchoring, opposite side helix-like anchoring. Pulling the thread, the defect is closed. CQ3, technique suitable for iatrogenic perforation. European Society states that OTC is a first option for closing large defect. Over the scope clip OTC is simple, similar to UL technique. Our review summarized that perforation was rescued with high clinical success rate of 95%. The associated complication rate was low with 1.7% in overall. This device is acceptable. Show video. Iatrogenic perforation occurs in the rectum. 10 millimeter perforation occurs. OTC is applied. Suction the defect into the cap. Through suction, OTC fire. The perforation site could be closed and could prevent surgical rescue. Several suturing devices are now developed. Our team had developed double suturing bar called Zeo Suture M. One side puncture, opposite side puncture, next triangulation. Or ligation. This is simple. Finally, next to our mission, our future missions are the following three missions. Previously, we had developed a protective barrier enclosure and barrier to prevent COVID-19 virus. The characteristic is patient covering negative pressure box based on academic approach. The reduction effect of exposure to examiner could be revealed. First, next generation endoscopic device developed and then national funding a medal. 4 devices are under investigation to get a patent. Second, medical engineering collaboration project. Green endoscopy is hotspot in Western countries for endoscopic SDGs. We launched Green Kagawa project. Slim device package may lead to medical waste and cost reduction. This is trend research. Third, cross-sectional research. Under large ML project, we are going to apply magnifying gastroscopy in diagnosing uterine cervical neoplasms. This concept provides high patient acceptability and may increase the tumor detection rate. This is Kaga University Labo. Many professors gather. We want a challenge for new endoscopic world. Many thanks for your kind attention.
Thank you, Professor Kobola, for presenting a really beautiful technique. I think I will let ask Professor Kobola first because I still don't know how to deal with the portal hypertension. Can I ask you for your technique, submucosal endoscopic submucosal dissection? Is there any role in management of patient with portal hypertension?
Sorry. Simplify.
Because it's under the topic of portal hypertension.
Yeah.
I still cannot imagine.
Yeah.
So that's why I ask, do you think or imagine any possibility of apply your technique in management of the complication of patient with portal hypertension?
Yeah. So sometimes this is a portal hypertension session. However, President so offers me to endoscopic new world. So in the portal hypertension field, so endoscopic techniques, so perhaps be applied. For example, so OTSC over the scope clip, so can stop the massive bleeding from variceal bleeding. So it's a potential ability.
Okay, any question from the floor? Okay, in that case, thank you, my Professor Kobola, for your presentation.
Thank you so much.
We move to the last speaker of this session, okay? Is role of hepatic blood pressure gradient in the management of portal hypertension, and it will be presented by Professor Hitoshi Maruyama.
Yes.
Professor Maruyama, please. And then after this session, we will invite Professor Quick to join the discussion, okay?
Thank you, Mr. Chairman, and good morning, ladies and gentlemen. My task today is to give a lecture about role of HBPG in the management of portal hypertension. These are topics of my presentation. And first topic is hepatic venous catheterization. There are two methods in hepatic venous catheterization. One is occlusion valve method, and the other is end-hole catheter method. If you look at the right panel, you can see balloon here. And if you look at the left figure, the end of catheter is placed wedged at the end of branch of right hepatic vein. This prospective study compared these two methods to measure pressure in 174 patients with cirrhosis. They also measured direct portal pressure after CHIPS procedure. And they found median absolute difference of pressure between direct and indirect method was much smaller, significantly smaller in occlusion valve method than in end-hole catheter method. Therefore, occlusion valve method is considered as standard. This schema explains how to perform pressure measurement. You can access either jugular vein or femoral vein, both connect to IVC and hepatic vein. If you use balloon, you can temporarily control the blood flow in the hepatic vein. This is an angiographic image, retrograde of venography, and the balloon occlusion using iodinated contrast material. Let me show you one study which reported impact of deep sedation on the accuracy of pressure data in patients with cirrhosis. There are 44 patients who underwent CHIPS over HBPG measurement, and they used sedation by propofol and remifentanil with a target controlled infusion system. You can see here, variation of pressure data became larger when they used deep sedation. Therefore, using deep sedation is maybe a pitfall when we perform pressure measurement. This is Baveno 7 consensus statement, which described detailed explanation for hepatic venous catheterization, pressure measurement. Let me explain the important part briefly. As I mentioned, deep sedation may cause inaccurate HBPG data. So they recommend the sedation by low-dose midazolam, 0.02 milligram per kilogram. And next, measurement of pressure. IVC pressure should be measured as internal control at the level of hepatic venous oxygen. Free hepatic venous pressure should also be measured in the hepatic vein within 2 or 3 centimeters of its conference with IVC. And West hepatic venous pressure measurement requires at least 1 minute recording with stabilization. HBPG is internationally accepted parameter. So we should know what is standard, and we'd better follow the standard procedure. Next topic is evaluation of hepatic venogram. This is a typical image of hepatic venogram taken in patient with cirrhosis. Vein-to-vein anastomosis is rare, and you can see wide angles between veins and their tributaries. Irregular stenosis of large veins and branches at various levels, and you can see here spotty sinusoidal fading. Also, retrograde detection of intrahepatic portal vein is a common finding. However, there are differences in the hepatic venogram between cirrhosis and IPH, which shows pre-sinusoidal portal hypertension. Vein-to-vein anastomosis, you can see here, is a common finding. And also you can see narrower angles between large veins and their tributaries. Smooth and wavy middle size to large branches with a whipping willow appearance. And also you can see homogeneous sinusoidal feeding. And important thing is retrograde detection of intrahepatic portal vein is very rare. So retrograde venogram, I mean hepatic venous catheterization, is very important to diagnose IPH and to distinguish between cirrhosis and IPH. Last topic is role of HBPG in clinical practice. I have two topics today, and one is classification of portal hypertension type. Because this is a postgraduate course, so I'd like to focus on fundamental issues. There are three types of portal hypertension type: prehepatic, intrahepatic, and posthepatic type. And intrahepatic type is divided into three patterns: pre-sinusoidal, sinusoidal, and post-sinusoidal pattern. Let me explain one by one. Posthepatic type is usually caused by congestion, like cardiac failure. Free hepatic venous pressure with the hepatic venous pressure, both are increased, but HBPG is normal. Free hepatic type is caused by usually portal vein thrombosis. HBPG, FHVP, and WHVP all normal. But please make sure actual portal pressure should be increased. And intrahepatic type is divided into three patterns. Pre-sinusoidal pattern is seen in IPH. HBPG, FHVP, and WHVP all normal, but we should recognize actual portal pressure is increased. Sinusoidal pattern is seen in cirrhosis. HBPG and with the hepatic venous pressure both increased, but FHVP normal. And last one, post-sinusoidal pattern, which is detected in Budd-Chiari syndrome. Unfortunately, we can't access the pressure measurement because of the obstruction of hepatic vein. But also, we should know actual portal pressure is increased. Taken together, pressure measurement and hepatic venogram is very important to understand the mechanism of portal hypertension. And next topic is assessment of severity of portal hypertension. This is a very famous old study reported by Garcia. You can see here on right panel, no one showed varices in case with HBPG lower than 12. And if you look at right, no one showed varicose bleeding in case with HBPG lower than 12. This next study reported relationship between HBPG and post-treatment outcome after acute varicose bleeding. You can see here HBPG is significantly higher in cases poor evolution, which is defined by early rebleeding or failure to control bleeding. And in the right panels, worse events after the treatment was significantly more frequent in case with HBPG higher than 20. Interestingly, almost similar data was reported in the paper published 9 years later. You can see here HBPG higher than 20 was significant factor to predict 5-day failure after acute varicose bleeding, which was defined uncontrolled bleeding, early rebleeding, or death. So HBPG is also effective to predict a post-treatment outcome. And also, reduction of HBPG by using medical treatment showed some beneficial effect on the patient. For example, you can see here, reduction of HBPG shows reduction of bleeding risk, and here a reduction of mortality. Based on this background, this famous Spanish study reported the effect of hemodynamic response guided therapy to prevent varicose rebleeding. This is open-labeled and controlled pilot trial, and actually they measured HBPG 2 times, one 5 days after varicose bleeding, and second measurement was 15 days after the initiation of nadolol and nitrate. There are 42 patients, and you can see here these two groups, I mean the drug therapy group and bonding and drug group, there was no significant difference in rebleeding rate and mortality rate, which shows the effect of hemodynamic response guided therapy. This next study also focused on HBPG guided treatment. There are 109 patients, almost half for band ligation with beta blocker group and the other for HBPG guided group. And you can see here, 3-year cumulative rebleeding rate was significantly lower in HBPG guided treatment group, which also support the effect of hemodynamic guided therapy. HBPG is also effective to predict clinical decompensation. This study reported 3 significant factors in compensated cirrhosis: HBPG, MEL score, and albumin. And you can see here, a patient with HBPG lower than 10 shows 90% probability of not developing clinical decompensation in the median follow-up 4 years. And also, HBPG is a significant factor to predict prognosis. Actually, this study was performed in patients with refractory ascites after CHIPS placement. And there are 2 significant factors. One is MELD score, and the other are, you can see here, HBPG. HBPG 16 showed highest sensitivity, and HBPG 25 showed highest specificity to predict their prognosis. This is the study regarding SCC. You can see here HBPG higher than 10 confers almost six-fold increase of the risk of developing SCC. While, curative reduction of SCC is almost diminished with severe portal hypertension due to increased morbidity and mortality. Therefore, current European guideline strongly recommends the cutoff value of HBPG-10 to consider the application of curative rejection of SCC. Let me summarize my presentation. Hepatic venous catheterization is a safe technique which enables measurement of HBPG and to characterize type of portal hypertension. HBPG has a great role to assess the severity of portal hypertension, to predict post-treatment outcome, to provide therapeutic direction and prognosis in cirrhosis. HBPG is a good marker to predict the occurrence of SCC and to judge the therapeutic direction of SCC. Thank you for your kind attention.
Thank you. Thank you very much. Now it's open for discussion. May I invite all speakers on the joint panels, please? Any question from the floor? Yes, please. Okay, good.
Good morning. I'm Manuel Mendizábal from Argentina. I have a question for Dr. Maruyama. Very nice presentation, and I agree that HBPG is a very useful tool. But nowadays, I believe that after the inclusion of non-invasive tests like elastography, maybe the use of HBPG measurement, it's not so needed as it was before, and it's an expensive method, and it's not available on every place, especially from developing countries like mine or regions. And so, saying that, what is your feeling regarding the actual use of HBPG? When can we use HBPG that it cannot be replaced by other methods like non-invasive methods? For example, for the use of early tips, we don't need HBPG as we did before. There are other uses.
Okay, but HBPG value cannot be completely estimated by non-invasive test. So still now, it's very important parameter which cannot be measured by other non-invasive markers. And second, in our country, CHIPS is not approved by government. It's not covered by insurance. So still now, HBP measurement is, I think it's a gold standard. But of course, I understand importance of non-invasive test. So we have some ongoing study to find the much better non-invasive test. Now we measure the HBPG by using IVR, and also we perform a non-invasive test.
I think a really good question. I mean, we know that palliative treatment of portal obliteration for the patient with significant varices. To see the hepatic venous pressure gradient responded therapy, it allow you to keep the right dose and get the maximum response. And in order to follow up this question, so very quickly you ask something because you talk about non-invasive technique.
Yeah, this is very important question for this field, but very unfortunately, we don't have any study to prove non-invasive method can guided beta blocker and improve outcome. None. If you search literature, non-study. So I can just say non-invasive is a promising, but no evidence improve. So this is why in my lecture, I show we do a RCT trials to improve if the non-invasive can guided therapy, because diagnosis is not for diagnosis, it's for guided therapy, right? If only diagnosis is not important, so we don't have data yet.
So every time you place a patient on beta blockers, you will measure HBPG to see if it is working.
In a predictor trial, they do that, but as I mentioned, in the clinical practice, no one do that.
Right.
No one do that. So
Okay.
we need non-invasive, but no data yet.
Okay, not
So
available.
that's reasons we want to kick off the RCT trials.
Okay.
It had to be initiated, investigator-initiated trials.
Okay, thanks.
I think we know from the invasive technique that if you are propranolol or non-selective beta blocker responder able to reduce the significant hepatic repression, you improve the outcome in terms of peritoneal hemorrhage and rebleeding. But liposuction, but it no data confirmed by non-invasive technique to that validate the result of non-selective beta blocker responder. So I'd like to follow your question regarding your study clinical trial. You look at the patient with the tension rotographic greater than 25, right? And without high risk of varic. But you put on the non-selective beta blocker, I think for your study, carbidopa, companion placebo. And I saw really interesting to see that you look the primary endpoint hepatic decompensation. So it means your aim not about prevent visual hemorrhage, right? Because you use the patient without high risk of varic. So what is the mechanism that it can prevent hepatic decompensation from that your clinical trial? Because you said you want to prevent hepatic decompensation
Yes.
by giving the non-selective beta blocker
Yes.
among those without high risk of varic.
Yes.
So you think what is the mechanism of non-selective beta blocker to prevent hepatic decompensation?
Yeah. So actually, our study, the design is very similar to the predictor trials, which was published in 2019 in the Lancet. The only difference is selection criteria. They use the HBPG more than 10, but I use the liver stiffness more than 25. A lot of proof, even if you can see in the latest ESO guideline and ASD guideline have the specific recommendation to use liver stiffness more than 25 to predict the CSPH. But as I mentioned before, no data yet to prove non-invasive guided therapy. And in the predict trial in the Lancet, they proved the beta blocker, including pranolol and carvedilol, can prevent ascites, and most of the cases are ascites, but still a couple of cases is bleeding.
I think now clearly we know that in the old day we try to use non-selective beta blocker in order to prevent the complication of severe clinical significant portal hypertension, and that means in the term of peritoneal hemorrhage. But many clinical trials in last 5 years, you could see that, like comparing the patient who underwent banding ligation and non-selective beta blocker. Of course, banding ligation can reduce the risk of peritoneal bleeding better, but for the survival, it contrasts non-selective beta blocker have a better survival. I think now we always agree with you that non-selective beta blocker, it not only reduce portal pressure, it might have some tokine effect. And clearly we know that it can improve gut permeability, reduce bacterial translocation, and also reduce systemic cytokine. And that can modify the liver regeneration or the prognosis regarding of hepatic decompensation that you can see recently. Any question from the floor? I think you have no further question because they give you really clear information. I would like to close this session, and before closing this one, please join me to thank Professor Kut, Professor Haruyama, and Professor Maruyama.
Let me say one thing. Japan is a very stupid country. TIPS is not approved by government also. using medical treatment like beta blocker is not also approved in our country. So please say something to our government.
No, so not approved for using in hypertension.
Yes.
Okay. Okay, so thanks for all three speakers and for your attendance. I would like to close this session. I think we will resume at 1:30 for the afternoon session, right? Thank you very much indeed.
Thank you very much to the lecturers and moderators.